Hey everyone, welcome back to Nurse Crit. My name is Chasen. I'm an acute care nurse practitioner. We've all dealt with barfing patients. It's just a part of the job. In order to help our patients feel better, we give them anti-nausea meds, or more properly known as antiemetics. You might be thinking, another boring video. Well, when I choose to make a video or Instagram post, it's because I know for a fact that many nurses don't fully understand the subject I'm talking about. So ironically, the ones that sound the most boring to you are probably the ones you actually know the least about. So don't click away. Let me help you elevate your nursing practice. In this video, we will review the mechanisms and receptors involved in nausea and vomiting, review antiemetic medications, and explore a couple alternative therapies for nausea and vomiting. The physiology of nausea is still poorly understood. Some of the key players involved in nausea and vomiting include the vomiting center, the chemoreceptor trigger zone, the vagus nerve, and the vestibular system. Various stimuli like infections, toxins, medications, or even motion can activate these receptors, producing nausea and vomiting. There are also several neurotransmitters involved in mediating nausea. These include serotonin, dopamine, histamine, acetylcholine, and substance P. And this is where our pharmacology comes into play. All of our antiemetics targets one or more of these neurotransmitters. The first and most common class of antiemetics is the serotonin antagonists. This includes your Zofran as well as Antiemetics, Kytril, and Aloxi. These medications selectively block the 5-HT3 serotonin receptors in the periphery and in the CNS. The main adverse effects include headache, malaise, constipation, and QT prolongation. The QT prolongation is a concern because it can lead to torsade de pointe, which is a fatal ventricular rhythm. However, at standard doses and the avoidance of co-administering other QT prolonging drugs, this is extremely rare. Serotonin syndrome is also a potential risk, but very unlikely when given in isolation. The risk really only becomes notable when combining multiple serotonergic drugs. These really are pretty safe and effective drugs in treating nausea and vomiting, and that's why they are generally first-line agents in most situations. The next class of antiemetics is the dopamine antagonists. This primarily includes Reglan, but it also includes some older antipsychotic meds like Thorazine, Haldol, and Compazine. All these meds block dopamine receptors in the brain and some in the GI tract. Reglan is unique in that it additionally blocks serotonin receptors and it sensitizes tissues to acetylcholine, which results in increased gastric emptying. Reglan may be used as a first-line agent, but more commonly falls second to the serotonin antagonists. The antipsychotic meds are definitely second or even third-line agents. The main adverse effects for these drugs include headache, sedation, hypertension, QT prolongation, blood dyscrasias, and extrapyramidal symptoms. EPS is an umbrella term that includes dystonia, akathisia, Parkinsonism, and tardive dyskinesia. These are all potentially permanent movement disorders we really want to avoid. The most dangerous adverse effect of dopamine antagonists is neuroleptic malignant syndrome, which is a syndrome of hyperthermia, muscle rigidity, altered mental status, and autonomic instability. This rare complication is potentially fatal. All of these horrible adverse effects are more common with the antipsychotics, and that's why they are not first line. Although Reglan shares the same list of side effects as the antipsychotics, it tends to be less pronounced. The next class of drugs to review is the antihistamines. These drugs include Dramamine, Benadryl, Antivert, and Phenergan. Obviously, these drugs block histamine 1 receptors, and they are primarily used for nausea and vomiting associated with motion sickness and vertigo. Of note, all of these antihistamines also have some degree of anticholinergic effects. Anticholinergic drugs are actually the next class of antiemetics I will discuss. So antihistamines really have a dual mechanism by blocking both histamine and acetylcholine. The adverse effects of these drugs include drowsiness, confusion, blurry vision, dry mouth, constipation, urinary retention, and blood dyscrasias. These side effects may be more pronounced in the elderly populations and should be used cautiously. Like I just mentioned, the next related class of antiemetics is the Anticholinergics. In addition to all the antihistamines I previously mentioned, the main anticholinergic used for nausea is scopolamine. This is most commonly used in the form of a transdermal patch that is applied behind the ear for motion sickness-related nausea and vomiting. I once had a patient who was receiving Zofran and it wasn't really working for her nausea. It seemed to worsen when she was getting out of bed, which sounded like a form of motion sickness to me. We tried a scopolamine patch, and sure enough, her nausea improved. As an anticholinergic drug, it blocks acetylcholine, which reduces the transmission of signals from the vestibular system to the vomiting center of the brain. Its adverse effects are essentially the same as the antihistamines, since the antihistamines also block acetylcholine. You can expect drowsiness, confusion, psychosis, blurry or double vision, dilated pupils, dry mouth, constipation, and urinary retention. The patches should be removed immediately if any psychiatric reactions occur, since the effects may continue to last for hours to even days after removal. Also, I personally would not recommend use beyond 3 days, as I have witnessed scopolamine patch withdrawal syndrome in my own mom after a cruise. She wore a patch for, I believe, 7 days, and when she got home, she was quite ill for the next few days. Scopolamine withdrawal occurs as a cholinergic rebound effect and can cause nausea, vomiting, headache, dizziness, abdominal cramps, sweating, confusion, muscle weakness, bradycardia, or hypotension. The longer the patch is on, the greater the symptoms. Withdrawal symptoms are much less likely if the patch is used less than 72 hours. If the syndrome does occur, it can be treated using meclizine. The fifth neurotransmitter I mentioned at the beginning of the video was substance P. However, drugs used to block this neurotransmitter are only used in oncology for chemotherapy-induced nausea and vomiting, so I will not review it any further here. Aside from the antiemetics I have listed thus far, there are some adjunct medications that are sometimes used. Benzodiazepines like Ativan and Valium are sometimes used to help with nausea and vomiting. They are used in oncology and postoperatively, and believed to be helpful for anticipatory nausea, like when a patient gets anxious about a procedure or event that has caused them nausea before. Another adjunct used in oncology, and sometimes postoperatively, is corticosteroids. This most often is Decadron. How it reduces nausea is not well understood, but it's believed to work due to its anti-inflammatory effects, and it may affect an area in the brainstem as well as reduce serotonin. Benzodiazepines and steroids are kind of the keep in your back pocket tool when conventional treatment isn't cutting it. Lastly, I will discuss two non-pharmacological interventions in the treatment of nausea and vomiting. The first is acupressure. Like most non-pharmacological interventions, the evidence is mixed, but I am a firm believer in trying anything that is safe. It may or may not work, but what's the harm in trying? During my time in oncology, I actually did try this on my patients, and it did help sometimes. On the inner or anterior forearm, you look for that skin crease line in the wrist area. 3 finger breadths down from this crease and between the 2 large tendons is where you apply firm but painless pressure. This is known as the P6 pressure point. I believe this is how commercial nausea relief wristbands work. They apply a continuous pressure to this pressure point. The final intervention that I'm a big fan of using is isopropyl alcohol. Believe it or not, those alcohol prep pads that nurses carry in their pocket is a fairly effective antiemetic. I've had many patients say it worked well, and I myself have tried it with good relief. You take 1 or 2 isopropyl alcohol pads and hold them about an inch away from the nose. You inhale deeply through the nose and exhale out the mouth. You can repeat this every 15 minutes or so. This intervention was actually studied in RCTs and found it reduced the need for conventional antiemetic drugs like Zofran and Reglan. As a nurse practitioner, many times I have been called because the Zofran isn't working well enough and the patient is still nauseous. Please try using your alcohol pads, maybe even before giving the Zofran. This intervention is cheap, readily available, does not require an order, works quickly, and it appears to be very safe. I think it's quite cool, and when it works for you or your patient, I think you'll agree with me. Your patient in particular will be very grateful if you can avoid the need for that $300 Zofran IV injection. Thanks for watching this video on antiemetics. If you found any of this information useful, please consider subscribing to my channel. Early subscribers are the most important for any channel's success. Share this video with all of your nurse friends or classmates and leave any comments or questions below. Thanks again, and see you all next time.